I have no financial interest in this presentation.
Strategies in eye surgery have become increasingly precise and reliable. By analyzing the most recent innovation in surgical strategies, this short presentation aims at providing some tips and tricks for a safe surgical performance. After defining what a safe performance entails, we discuss the ways in which technology might enhance technique. Then we briefly present the main fields of innovation in surgical strategy. Finally, we conclude by presenting the combination of surgical devices and machinery setting that, according to us, can guarantee an optimal result. The presentation is complemented by 3 short videos which help to visualize the concepts presented. The surgeon is interested in those strategies that maximize the safety of his performance. In this respect, the optimal surgical strategy should minimize the overall duration of the surgery while maximizing the use of surgical machinery. In addition, it should allow to identify anatomical structures and the relationship between them, if pathological or not. An increasingly better performing technology might enhance surgical technique. However, there is a slight trade-off between innovation and reliability. Here the technique and the experience of the surgeon come into play. Depending on the situation, he or she might try new technologies or prefer an already tested to be reliable technology. Technological innovation in vitreoretinal surgery has mainly concerned the following fields: instruments and machineries, illumination systems, dyes and filters, wide field vision systems. As for machineries, small gauge entrockers have been introduced. Infusion and fluidic control have been enhanced. A higher rate of cuts per minute, a more controlled duty cycle, and vitrectomy probe mouth positioning have made the surgical procedure safer. As for illumination systems, the range of light sources is wide: xenon, photon, mercury vapors, diodes. However, they might all cause phototoxicity. The photochemical damage can be detected thanks to the autofluorescence property or RPE, as explained in this slide. This issue can be limited through the use of filters. In particular, the use of the amber filter increases the safety of the surgical performance by at least 30 times as compared to the standard 420 nanometers filter, as shown in these graphs. Dyes could also be used to limit the risk of photochemical damage depending on the type. There are different types indeed of dyes: brilliant blue, ICG, lutein, and purple. While the brilliant blue and ICG dyes might increase the risk of retinal damage, the purple and lutein-based ones have been found to have a shielding effect. In order to help and visualize in a simple and clear way the concepts so far explained, we now look at 3 short videos. The first video shows the soft injection of the purple dye and its removal directly with the vitrectomy probe. This is a typical case where technical reliability, here at the 27 gauge, allows for an innovative surgical performance. Indeed, the membrane of the pucker is taken directly with the 27 gauge, without using a retinal pick or forceps. In the second video, we show instead the use of a lutein-based, thus natural, dye. It is less toxic and it also filters the light, thus shielding the eye from the light source. The peeling is performed under the amber filter, which provides the maximum filtering possible to the benefit of macular photoreceptors. In the third and final video, we see instead the use of the different filters, yellow, amber, and green, in the clinical practice of appealing. If we wanted to write down a checklist for limiting the risks of phototoxicity, it would entail a reduced power of the light source. Here, surgeon's vision adaptation plays a role. No concentrated light, wide-angle probes should be preferred. A greater working distance, thus shorter light probes. Use of a filter, preferably amber. Use of dyes, preferably those with a shielding effect, like the purple and the lutein dyes. A reduced surgical timing. Finally, tutoring throughout the whole procedure is provided by intraoperative OCT and operative vision systems, which provide a valid overall vision of the eye. IOCT gives the surgeon absolute control of the anatomical of the eye's reference point. Non-contact wise vision systems instead help surgeons visualize peripheral retina. Here we can see the difference between the ReSight and BIOM systems. To conclude, our tips and tricks for good surgery would entail small gauge, non-contact wide field system, purple or lutein-based dyes, amber filter, IOCT. In order to possibly prove the benefits of the practice suggested, we would like to report some data. In the past 5 years, we have had 734 vitreoretinal cases, all with different clinical histories, whether a pucker, a macular hole, or a retinal detachment. The anatomical results of our suggested best practice have been encouraging. No post-operational infections, no IOP rise, a 2-line medium gain, recurrence of retinal detachment for only less than 1% of cases. Thank you for your time.